So it's 12 and shall we start right on time? Okay. First thing is, thank you for those who have taken out time to come and join us. Can you put the slides on the screen, please? Okay. First of all, why do we have this program? This is not a very elaborate course. The entire purpose was to come up with day-to-day problems that all of us face in our ophthalmology clinics. This is what a typical OPD looks like, crowded. Most of these patients would either have a refractive error or a cataract. Some of them would have glaucoma and other problems. Oculoplasty hardly takes up about 5% of your caseload. But the problem is, among some of these would be lurking some of the dangerous ones, the ones that are potentially life-threatening or sight-threatening. So we're talking about tumors, some of them being malignant tumors, and that is the point of this entire exercise. In a busy clinic where you have to see a lot of patients in a short time, it's a risk getting missing some of these. In the morning, we had a free paper session where it turned out that 38% of retinoblastoma patients were being misdiagnosed by the ophthalmologist on the first visit. Now that's a big number because ultimately an early diagnosis is what leads to a situation where you can salvage the eye or you can salvage life. The same problem happens with other tumors as well. So this is a very basic course where we are not going to be talking about treatment in detail, but mainly about recognizing disease, pattern recognition, early diagnosis. So that would be our objective. So my name is Anirban Bhaduri. I'm a practicing ocular oncologist. I work in Eastern India in Kolkata. And I'll be talking about eyelid tumors. We have covered the entire spectrum of tumors which are important for the ophthalmologist. And there is a slight change in order. So Dr. Seema Das would be talking about retinoblastoma. That would be followed by Dr. Roshmi Gupta, who is from Bangalore. She works in the Trustwell Hospital. She used to be with Narayan Netralaya for many years, but now she's moved and is practicing in multiple institutions. And from further south, we have Dr. Vikas Menon, who's going to be talking about ocular surface tumors. So without much ado, we'll proceed with the body of the instruction course. So how many of you are movie fans, cowboy movie fans? Raise of hands. We can all come forwards because we want this to be as interactive as possible. And how many of you have seen this particular movie? Okay. Maybe some of you haven't seen the movie, but you've heard the signature music that comes with it, where there's a coyote calling in the background. Now, I've been a movie fan all my life, and this is one of my favorite movies. I remember bunking college to go and see this in a hall. But why I chose this as a topic was because these three characters in the movie define exactly what we do when we see tumors. So you have the good, you have the bad, and then you have the ugly ones as well. But if you have seen the movie, you will realize that they all are not clean black and white characters. They all have shades of gray. I hope we'll be able to bring this out in the course of this particular instruction course. So what are we actually looking at? What are we really interested in? We need to take certain management decisions, right? First of all, the most important step, of course, being what is the disease? And then, if you're not sure about what is the disease, at least what is the nature of the disease? Is it good? Is it bad? Or is it just ugly and not as bad as it sounds? The next very important decision that needs to be taken is what is the extent of the disease? Okay, because that is also going to affect your management decisions. Finally, once you have the answers to the first three questions, would you decide how would you manage it? Now, some of these are situations which you can manage in your own clinic, in your own institution, and in certain other situations, you can take a decision to refer to the nearest available person who specializes in treating such conditions. Okay, look at the good ones. Why do we say the good ones? Because they will not kill you, or they will not kill your patient. So we look at certain cystic masses. Now, this is very common, right? An acrine cyst of Moll, and this typically is whitish or slightly yellowish, doesn't transluminate very well because of the nature of the contents of the cyst, arise in the lid margin. But this is another one which is bluish, translucent, it transilluminates, and sometimes you will also see a bluish deposit at the bottom or sediments at the bottom. Now that's an apocrine cyst. Now these are both sweat gland cysts and they are benign. Look at these multiple cysts which also arise from sweat glands, which are syringomas. And this is a common condition which because of blocked sweat glands, which is known as milia, which is often seen in heart condition. Now, all of these are benign conditions. All of them are cystic lesions. Okay. This used to be earlier known as a sebaceous cyst, typically identified by this punctum that you see on the top of the cyst, arises from sebaceous glands, or actually sebaceous gland around a hair follicle, which is why you get that punctum. Okay, let's look at solid lesions. Now, this is a slightly unusual presentation of a very common condition. This. What do you think is it? Common inflammatory condition of the eyelid. So this is actually a very large chalazion. Okay. So you evert it and you can see the swelling is more prominent on the posterior side of the eyelid. This pale, non-pigmented lesion with distorted lashes arising from the lid margin. The distorted lashes are important, number one. And number two is these lashes are often hypertrophic. It's been there since childhood and has been growing gradually. Common lesion. What is uncommon is the color. So that's a margin nevus. Okay. Why is it different? Is because it is not pigmented. This is a spot diagnosis, right? This is a 3-month-old child, a rapidly growing lesion, a capillary hemangioma. This has a surface. Look at this solid lesion. This is an elderly patient. It's a solid lesion which has a surface which is very similar to a walnut. And you know what the surface of the walnut looks like? It matches one of the structures which is there within our protective cranial cavity, right? So it's a cerebriform surface. This is typical of a seborrheic keratosis. Seborrheic keratosis can also have a papillary surface which weeps, which looks unhealthy. But this is one of the forms of seborrheic keratosis. All of these are benign lesions. What would you do with benign lesions? So benign lesions can be excised in toto. All right, your excision would be limited to the location of the lesion. All right, this is something that is often mistaken to be a chalazion. This is a tarsal cyst. Okay, let's look at some of the bad ones. Any answers to this? So it's arising from the lid margin. Part of it is pigmented, part of it is shiny, pale. Louder. Louder, please. Purban, I'm waiting for your answer because I can hear you saying it. I'm a little hard of hearing. So this is a small nodular basal cell carcinoma. Okay. Okay, what is this? rolled margins, central ulceration. This is also basal cell carcinoma, but this is nodular ulcerative variant. This is the marking which we will refer to very soon. You see the marking beyond the lesion. Okay. Okay. A larger one. So part of it is pigmented, part of it is not. But this is again a nodular ulcerative basal cell carcinoma. This is more subtle, more diffuse, not a typical nodular or an ulcerative lesion. This is the morphia form variant, and this is the worst kind. So because this can infiltrate under the skin and go beyond what is apparently visible on the surface. Okay, so all of these were basal cell carcinomas, which are apparently the commonest tumors in the West. In our country, it more or less matches the next tumor that we're going to discuss about. Okay, so pearly lesion like the early one, and larger lesions would have the rolled edges. These are all locally destructive. They hardly ever metastasize. Okay, but they could invade the orbit, they could destroy bone if you leave it unattended. This is our other tumor, more common among Asians like us, and it has a typical color. It is yellowish. And as Sir says, this is the sebaceous gland carcinoma. Okay. Let's see some more sebaceous gland carcinomas. Look at this lesion. You can see this nodular swelling here. If this was not there, you would probably think it is a chalazion, which is why every time you see an eyelid lesion, always evert. Then only you will get to see the true picture. And you see this is the nodular component of the tumor. There is also a flat papillary component which is extending way beyond the nodular lesion that you're seeing. And that is pagetoid spread, which is very typical of a sebaceous gland carcinoma. So your excision is going to be even beyond that. Right? This is a more destructive lesion. So you see the tumors in the upper lid, destruction of the lower lid. There are also small nodules on the conjunctiva as well as on the limbus. And this patient also had involvement of the lacrimal sac. Because like you have pagetoid spread, you could also have something called onchoria, where tumor cells actually flow with your tears and enter the lacrimal drainage system. It's something to watch out for. Okay. So these are all sebaceous gland carcinomas, and what is important is the color. Okay. And the location. Let's see this one. This is more diffuse. And although it has this whitish appearance which seems to look like keratin, this is not OSS, this is sebaceous gland carcinoma. This is the typical pagetoid variant. You don't see a single nodular lesion here, except you see thickening of the lid margin. In some areas you also see what? Lack of eyelashes. So there's been destruction of the hair follicles. Right? So here we have a mix of lesions, some of them benign, some of them malignant. Now what distinguishes malignant from benign? So these 3 points: the loss of eyelashes, telangiectatic vessels over the lesion, and thickening or distortion of the lid margin. All right, if you can remember these 3, you more or less know whether you're dealing with a malignant or a benign lesion. Let's look at this patient. This was diagnosed by a colleague who works in one of the districts far from Calcutta where I work, right? And this is a doctor's wife. And she was referred for this inflammation that is there in the lid margin, which was not going over with steroids. So she'd been seeing multiple doctors until she reached this gentleman who also practices pediatric ophthalmology. So he felt there was something suspicious. Now here you don't see destruction of the lashes, but there is a thickening of the lid margin, and there is the same whitish appearance that you were seeing in the previous case. And we did an incisional biopsy, so this is what is happening with the lid everted. This is probably an extent of pagetoid spread. Is my time over? I have only 1 minute. Okay, I think we should rush. Sorry, my fault. Okay, my introduction, 5 minutes. Yeah. So in a malignant tumor, this is how you would change your strategy. You would go beyond the visible tumor margin. So you do a wide excision. You also want margin control so that you know whether your excised margin is free of tumor. If you have frozen section control, great. Otherwise, you can ask your pathologist to expedite the examination of the margins and then go ahead and do the eyelid reconstruction. In sebaceous gland carcinoma, additionally, we would also do conjunctival map biopsies. Okay, so each biopsy is put on a filter paper, marked, and you would maintain that map with you in your records and then wait for the reports to come. If there is pagetoid extension, then you would either have to do cryotherapy to those areas or add mitomycin C drops. Okay, there are certain situations where you cannot do an excisional biopsy. Like this tumor, we do not know what it is. So to able to make a diagnosis, you would do an incisional biopsy. This turned out to be a Merkel cell carcinoma. Look at this other lesion. Large swelling, mostly on the posterior surface of the eyelid. This was a lymphoma, a diffuse large B-cell lymphoma. This is that patient where we wanted to do destructive surgery simply because there was no way we could salvage the eye. But you need a histopathological diagnosis before you go for it, right? Before you do a destructive surgery. So there again, you need an incisional biopsy. Here, we were not actually sure of the diagnosis, which is why we did an incisional biopsy. We had a suspicion, but we needed proof. Okay, now look at some situations where we don't know what it is. So this crater-like lesion, a keratoacanthoma, this could be malignant. Okay, this is the common situation that we see. You see a skin tag, but at the base of this, you could have a malignancy. So these are situations where you excise the entire base and you look for the pathology in the base. These may be benign, but they could also be malignant. Okay, this is the gentleman who has multiple lesions on the eyelid. See, 1, 2, 3. 3 different pathologies in the same. So that could happen to your patient as well. Right? Okay, these are the ugly ones. 2 minutes? Ugly one. Look at this ugly looking thing here. This is the benign condition. This patient has a seborrheic keratosis. But how would you prove it? You need to excise, right? Look at this other one. Ugly lesion that has been there for a year. This is what happens when you evert the lid. There is actually a normal lid underlying that pedunculated mass. And this was a very large papilloma. Again, a benign lesion, but we were not sure. We thought it could be a squamous cell carcinoma. Okay, my last ones. So you have these pigmented lesions in the eyelid. These are not meant to be excised, but the reason why we are showing you these slides is because there could be underlying disease that we need to be aware of. And as ophthalmologists, it's our duty to keep doing our dilated fundus examination for these patients for the rest of their lives. Okay. You know what is this? Sturge-Weber syndrome. The tumor that you're looking for is a diffuse hemangioma of the choroid. All right. This is ocular dermal melanocytosis, otherwise known as the nevus of aorta. And what is the tumor that you're looking for? Is uveal melanomas. Okay. What is this? I'll tell you what is the diagnosis from outside. It's a plexiform neurofibroma. But what is the associated syndrome? Is neurofibromatosis type 1. Look at this child. There are patches of abnormal skin here where there is no hair growth. Okay, along with these abnormal looking chorostomas. I think we'll skip it. Last, what are these lesions? I'll give you a hint. They are umbilicated. Molluscum, right? Now look at this kid. Mollusca, large mollusca. Several of them. Is there something that you need to suspect? This child is 2 years old. He turned out to be HIV positive. Okay, I'll stop here. So we'll do questions at the end of all 4 talks. And I'll invite Dr. Seema Das, who is from Shroff Charity Eye Hospital, Delhi, to talk about retinoblastoma. Dr. Das.
Thank you, Dr. Anirban. Okay, so can we have the slides, please? So I'll be talking about the unholy glow. I mean, we are going from eyelid straight to intraocular, but I think next to eyelid, what you see is the glow which is there in the pupil. And I'll focus mainly on retinoblastoma, and if time permits, try to cover a few more intraocular tumors. So we all know about the white glow in the eye. A normal pupil should have a nice, healthy red glow. And if that is absent, there is something wrong in the eye. It could be a tumor, but it could be many other things. But what we have to rule out is a retinoblastoma, which is a life-threatening condition. So it could be sometimes because of cataract or PHPB, pupillary membranes. And we all know why this term, what we call is leukocoria or a cat's eye reflex is used. That's because of the reflex what we see in the cat's eye, and that's because of the retinal pigment which is there. And that's how it looks like many times. But unless proven otherwise, a white reflex in a child's eye is retinoblastoma, and at least that needs to be ruled out before we plan anything else. Cataract can also cause a white reflex in the pupil, but if it's a congenital cataract, more often than not, it could be bilateral, and if we see it under slit lamp, the white part or the reflex is localized to the lens and not behind the lens, unlike in RB where the problem will be in the retina or the reflex is going to be coming behind that. And cataract have different morphology, and a good slit lamp evaluation is enough to give you the diagnosis. Coats disease, we all know, it has retinal telangiectasia, sometimes present with a total retinal detachment, especially the stage 4 and the stage 5 disease. But it again has the characteristic appearance, going by the history, going by the gender distribution. More often than not, we will get the diagnosis, and B scan and a CT scan is enough to confirm the diagnosis. Ultrasound in a stage 5 disease will show a close funnel RD without any intraocular mass. Sometimes the exudate can be a little thick, which can give an impression that there is some intraocular small calcification sort of thing, but there is a typical after movement if we do a dynamic ultrasound, and that might help in giving us some clue that we are dealing with a coats and not with an RB. Other things like persistent pupillary membrane, we know that the eye is going to be microphthalmic. We can see the elongated ciliary processes. There will be a retrodental fibrovascular membrane, and a B scan again will show no intraocular mass, but a closed funnel RD picture. So these again are sufficient to give us the diagnosis. Now, once we have ruled everything out, a leukocoria white glow in a child's eye is RB unless proven otherwise, and we must investigate further to rule it out. Because if we do not pick it up at this stage, this is what most of the children will end up with, and this is definitely something we don't want to see any day. Now, why it happens, why do we miss it? Because it's not always the child is going to come up only with a white glow. There can be many other variable presentation, what we call as the atypical presentations of retinoblastoma, and that's what is lets you miss the diagnosis. Now, if you see this child, for example, this is a representative picture of a child. I don't have the actual picture, but a very similar appearance of a 5-year-old child who was diagnosed as Coats disease elsewhere. It was a blind eye with a neovascular glaucoma diagnosed as a stage 5 Coats. But since the eye was little painful and the family was very keen on retaining the eye, not keen on getting a surgery done, the surgeon gave an option, the retinal surgeon gave an option of draining the fluid and injecting silicone oil so that the structure of the globe could be preserved. So he underwent that procedure. When he came to us, he did have an old B scan with us, and this is what the B scan showed. There was what was presumed as a retinal detachment with subretinal exudates, but if we see carefully, there are some high spikes within the retina, which possibly were areas of calcification. So unless and until we do a corresponding A scan with a B scan, we will miss out these areas of high reflectivity, which could be areas of calcification. And if it's a diffuse involvement of the retina, especially the variant where there is no definite mass in the retina, but the retina is diffusely thickened, which are the cases which present with a total retinal detachment sometimes, we might miss the calcification spots if your cursor is not exactly on the side where the high spot should be. So this child underwent a drainage of the fluid, injection of silicone well with some vitrectomy possibly, and when we saw him 6 to 8 months down the line, this was the picture. Now, there is no doubt about the diagnosis. This is an extraocular retinoblastoma. Typically, if you see, the tumor is coming out from the site where the ports for the vitrectomy were probably made, the supronasal nasal, temporal, and other sites. We got an MRI. The eye was already enlarged in size. There was some thickening of the proximal optic nerve also. So this has already gone beyond the eye. It's an extraocular RB, stage 3. His CSF was negative. He is still under treatment. But this is one situation. Probably a little careful assessment could have avoided the child going into this situation. Had an enucleation been done at a stage when the child was here, it would have made a difference of life and death for him. So it's important that all retinal detachment codes, before we say it's codes and before we do an intervention, we have to be very, very careful. And even if we are planning an intervention, we have to ensure that the drainage is closed as much as possible. And the fluid definitely should go for cytology, even if it is there, so that we are able to pick it up at a stage and do an intervention. Another child, so this child we saw long back, it was referred to one of our outreach clinics. In fact, the child was picked up there. He came to one of the vision centers because the parent gave a history that there was some trauma several months back, and following that there was some redness of the eye, and eventually the eye started shrinking, and they were very keen on cosmetic appearance, so they sent the child for a prosthetic eye fitting to the ocularist clinic. Now again, when we took the history, little detailed history, it was not fitting in. The trauma was too trivial to cause a hyphema and let the eye go into phthisis. So it was not really fitting. Plus the duration between the onset of trauma and the onset of the symptoms there was a several months gap. Generally, parents tend to attribute everything to trauma. It's very easy for them, but we should not buy that history very easily. A little deeper digging is required before the actual picture comes up. So then, since we are not very convinced, we put the child under EUA just to have a better look and also to see the other eye. And this is what we found. There was an anterior dislocated lens. It was a cataractous lens, anteriorly dislocated. There was some corneal blood staining, possibly. But again, the trauma was not getting explaining this dislocation of the lens. So we got a B scan done, as is the protocol for any child presenting with an unexplained phthisis. B scan is a standard, and you can see the evident calcification with an intraocular mass. So this was a little atypical presentation because RB, we know, does not present usually with cataract with lens dislocation, but this child did have that component. Maybe the eye was ophthalmic, the zonules were disrupted and the lens got dislocated. But what was missing with the initial B scan with the consult initially, which was done with the local practitioner? So, but luckily, since the tumor was already inside the eye, we just enucleated, fitted with the prosthesis, and he was doing fine. So phthisis bulbi can be one of the pretty common presentations of RB, especially in our settings, because more often than not, we see tumors which are pretty advanced. So if the tumor is group E and beyond, and it has outgrown the blood supply, there undergoes tumor necrosis. When the blood supply is not able to keep pace with the growth of the tumor. So when there is a tumor necrosis, the eye gets inflamed. They have picture of anterior uveitis, sometimes the orbital cellulitis, and subsequently the eye will go into phthisis. Now this young child again was sent because the eye was phthysical. There was some episode of cellulitis. Eye went into phthisis. Again, the concern was more from the cosmetic point of view. But as a protocol, again, B scan. This is again a representative B scan. I don't have the B scan of this particular child, but I do have the MRI of this child. Now, when we did UA for this child, we found a small tumor in the other eye. So we did not have any doubt about the diagnosis. But what is striking here, look at the brain. There is a trilateral retinoblastoma, pinealoblastoma. So bilateral RB, we know when they are germline, there is a possibility they can have a pineal gland involvement, and it can be a pinealoblastoma. This child was started on treatment, chemo reduction. He initially responded to some extent to chemo. Even the pineal gland tumor responded, but subsequently it came back. He was a young child. We could not give too much of radiation. He is still on treatment, but we know the prognosis is not that great. So at least even if you're not able to save these children, prognostication is important. Had the pineal gland involvement not been there, it was a bilateral RB, this child could have been easily salvaged. So it's important that we don't disregard all phthisis just as phthisis, and have a deeper look, try to understand what is the cause a little better and investigate them specifically. Hypopyon and hyphema are other common presentations. So any hypopyon where the eye otherwise looks quiet, there is no history, and the color of the hypopyon is little different. There is no intraocular, there is no ciliary congestion or any other antecedent history. We should be suspicious. At least get a B scan done, even for hyphema. History of trauma should not be taken just like that. It should be taken with a pinch of salt, and a B scan is mandatory even if you are planning any or not planning any intervention for drainage of the hyphema. Anterior uveitis, like this child had a very typical presentation of anterior uveitis where there was a lot of anterior segment seeding of retinoblastoma. In fact, this child was initially treated as anterior uveitis, wasn't steroid. This was again seen by a retinal specialist initially because they found nothing in the fundus. This was the fundus picture, which was a 30-degree fundus picture. Nothing was there. But since the uveitis was not responding, it was sent for further evaluation. B scan, by and large, okay, looks okay on a cursory glance, though if we see carefully, in this area, we can see something near the coats. So there is something there, but if somebody does not see carefully, we'll miss it. On a B scan, we can pick up the calcification, extreme peripheral, but yes, it is there. And when we got in white field fundus photography done, we can see the anterior tumor. So this was a variant of anterior retinoblastoma where sometimes, yep, you want to? Yeah. Yeah, because the color is different. Fungus will be little more yellowish. The exudates that we see in infection in the anterior chamber, they're little more yellowish. Retinoblastoma is white and fluffy. They are not yellowish. Yes, and there is lack of inflammation in the eye. Infection in the eye will cause some inflammation, which is missing in this picture. So these, and in a child, unilateral presentation. So these are good enough to raise a suspicion that, it is not really a simple infection, but it's something else. So this child, because there was a lot of anterior chamber seeding, this child eventually underwent enucleation. So this was a variant of RB called anterior RB. Another child, this was a young child with a ophthalmos, but we can see the bad glow in the eye, and there is no doubt that it is an RB with a secondary ophthalmos. In younger children, the eye can enlarge very rapidly, unlike in old patients. So they can accommodate the increased pressure, and you can see some NVI and an enlarged eyeball. So any ophthalmos needs to be, before we do any intervention, a B scan is mandatory to rule out any secondary cause for the ophthalmos. We mentioned about the orbital cellulitis picture, which is essentially because of the tumor necrosis. Some of them can come at a stage, but again, we need to look at the glow. We need to do the B scan. If required, we can get a CT scan done to look for the calcification, and they respond to high-dose chemotherapy. Now, once we have this suspicion, which is going to come from the history, a detailed examination is absolutely important. And history should cover this point: since when, how, what is the birth history, any redness, watering, pain. Most of the things which we discussed needs to be covered. Specifically, vision needs to be checked for. We should look for squint. That can be a presentation of macular retinoblastoma, where the glow, the leukocoria is still not there sometimes, and pupillary reaction needs to be looked at. So this is, and it's imperative that we take up these children under EUA for a more detailed evaluation. Many a times they will not cooperate for the evaluation in the clinic. So EUA almost always has a sequence, how we do it. We check for the anterior, we go from the anterior to posterior, check for the intraocular pressure, check for the anterior chamber, measure the corneal diameter, do an indirect ophthalmoscopy, and if any further investigation like B scan, UVM, whatever is required, fundus photography is required, all these things can be done at the same sitting when the child is still under GA. Once this is done, then we are pretty sure about the diagnosis. And then imaging, if we have not done under UA, we can get it done. And it's important that a corresponding A scan is done with the B scan to get the correct diagnosis. CT scan, usually for RB, it's recommended. MRI is recommended, but there are certain situations where we get a CT where we have the doubt about the diagnosis, where we are not sure whether it's RB or not. So sometimes to look for the calcification, a CT might be a better option. But if it's a germline tumor, bilateral RB, young children, we generally tend to avoid a CT scan and go for an MRI. Now, in a situation like this, I just put up this slide to emphasize the fact that even in a thyssecal eye, it's important to do an imaging. Don't presume that thyssecal eye cannot have RB or cannot have extraocular extension of the tumor. The eye might look thyssecal, but the tumor might be there in the optic nerve. So that's why it's imperative, like we can see the intraocular calcification in the CT scan in both the eye of this child, which is not in the coats of the eye. Thyssecal eye can have coats calcification, but any calcification within the vitreous cavity is not normal in a thyssecal eye. We need to rule out an RB in these cases. Just one more important thing to emphasize before we stop. And imaging is also important in a situation like this. If you see this child, he has an unilateral RB, little elder child, but there is a subtle proptosis of the eye. The eye is slightly prominent as compared to the other eye. Now, if you do not look for it carefully, we will miss this prominence of the eye. And many a times, these are the children who will undergo a primary enucleation. And sometimes an imaging is not done, presuming that the tumor is intraocular, an imaging is not done, and this child undergo primary enucleation. Now, a subtle proptosis could be an indicator that the tumor might have gone out to the optic nerve, subtle involvement of the optic nerve, as is evident on the CT scan here. And if we do an enucleation in this situation, and if you don't get an adequate optic nerve, if you cut it here, the nerve seems to be thickened till here, you will end up leaving behind some residual disease, and that is going to drastically change the prognosis. If we know beforehand that there is an extraocular extension, we can give some preoperative neoadjuvant chemotherapy, reduce the bulk of the tumor, and then go for the surgery, which is going to make the surgery safer. So we did the same thing for this child, and after just 2 minutes more. After a couple of cycles of chemo, we now see that the eye has shrunken nicely, the optic nerve thickening has gone down, and at this stage, the surgery is much more safer. And in fact, we recently did a study, it's an ongoing study, pan-India study. We found that almost 15% of the patients of retinal blastoma, many of whom have undergone primary enucleation, a preoperative UA or a imaging was not done before the child had gone for surgery. So that might make a lot of difference, and it's imperative wherever required, we get an imaging. This we already discussed in MRI, bilateral child, germline child, just to rule out an pinealoblastoma. It's mandatory for documentation, a baseline. And going on to the treatment algorithm, it's according to the group of the tumor. Small tumors, just focal therapy like TTT is enough. Larger tumor, we go for chemo reduction along with focal therapy. It could be cryo, it could be laser. And then for vitreous seeds, we have different modalities of management. I will skip this video, how to give the injection. And vitreous seeds respond pretty well to intravitreal chemotherapy these days. And for more extensive retinal tumors like group D and group E, some of the group E, not really all of them, but essentially for group D, we can resort to intraarterial chemotherapy if that facility is available, but we have to carefully select those patients. Generally, right now in our setting, because of the cost and all, we are restricting it only to the secondary patients, mostly to the secondary patients or unilateral group D patients who are not responding to other modalities of treatment or to a conventional chemo. This was one child, unilateral, other eye is enucleated, multiple recurrences, already had, I think, 16 cycles of intravenous chemo, still came back with a recurrence. We gave her a couple of cycles of triple drug ISC and 1.5 year follow-up. She's doing fine. The visual prognosis, of course, is poor. The disc is pale, but at least the eye could be retained. So there are some criteria which are the eye which are suitable for ISC, needs to be carefully decided. The tumors which are coming over the calcification, or there is a recurrence over the calcification, or a localized tumor following chemo reduction, these are good options for plaque brachytherapy, like this child where a plaque was done for the localized residual tumor, responded pretty well. Neoadjuvant, we already discussed. Enucleation remains one of the common modality of treatment, at least in our setting. Important thing here is that if you are doing an enucleation, it's imperative that we take a long optic nerve stump, at least 10 to 15 millimeter, and the histopathologist or a pathologist has to carefully look at the histopathology to look for high risk factor. Whether these children need further treatment or not, we have to figure it out. So I think I'll stop here, and if there are any questions, we can discuss.
Can we have questions now for Dr. Das, because she has to move to another session. So she won't be available for the discussion later.
Okay.
Any questions on retinoblastoma or the unusual presentations where we sometimes misdiagnose and mismanage? We can have them now.
All clear.
I think you made your point.
Okay, thank you. Thank you.
Thank you, Dr. Das. Dr. Roshmi Gupta is coming up next. She'll be talking about proptosis and, of course, tumors of the orbit, which go along with it.
Good afternoon, Dr. Anirban. Thank you for involving me in this instruction course, and it's a pleasure to be with all of you here today. And I'm Dr. Roshmi Gupta. I practice orbit oculoplasty ocular oncology in Bangalore. These are my former affiliations, and I have no financial interest in the products mentioned. So we'll discuss the approach to orbital tumors under the following headings: how we arrive at a provisional diagnosis through history, clinical features, imaging, and preliminary investigations, how we arrive at a tissue diagnosis, and how we plan management. So pediatric proptosis is in a group by itself. If we see the amount of proptosis is not so much, but you do see a trilateral lesion, and you can see the bone destruction. You know that it is a malignancy, and this is a primitive neuroectodermal tumor. It could be a retinoblastoma, as Dr. Seema pointed out. I think this is the wrong presentation. This looks like the wrong presentation was loaded.
Roshmi, do you have your laptop with you? Okay. While we're waiting, any questions on eyelid tumors? Or should I ask questions? Professor Ganguly is here.
Difficult to manage, or say a BCC involving maybe the SAC area, or both lid involvement is there medially. What kind of approach you like to have for these kind of patients when we do not have a frozen section?
Okay. See, one thing is, how soon can your pathologist give you a report on a permanent section? Yeah. 3 days is very good time. So, if you have that facility where within 3 to 5 days you can get a report on your margins, then you might as well wait. So you remove the lesion with your additional margins, and then you wait. Okay, you keep doing daily dressings, and once you have the report, then you'll have to refresh the margins and then do your reconstruction. So your reconstruction would be planned depending on what you have. You're talking about a situation where you've lost both the um, medial side. So yeah, so you have several options. You can take a midline forehead flap, divide it into two and bring it down. Okay, or you can do it separately. So for the upper lid, you can do a rhomboid flap. Or what is this called? I'm beginning to forget. Huh? No, the flick is for the lateral side. And for the lower lid, you can take an azojugal flap. So you can combine two flaps. All right. The Actually the eyelids are quite forgiving. So yeah, after all these years, what we realize is you do what you do, and you do reasonably well, the eyelid will open, and it will close as well. Okay, not really a problem, but just keep doing it. As long as you do not have tension in the wounds, you should not be having a problem.
About the conjunctival map biopsy, I mean, in a setup like where I work, it is difficult.
So conjunctival map biopsy is something you can do anywhere, right? You just need a pair of corneal scissors and you need a filter paper. So we send all our samples, whether we are doing lid tumors or we do conjunctival tumors, we put all our samples on filter paper. So I use Wattman filter paper #1, which is commercially available. The purpose is that you can make a drawing, you can make a geographical drawing, right? Or a map, and put the lesion exactly, your tissues exactly where you did that. Why is it important? Is because the pathologist will know the orientation of your tissues. Okay, you have a mental picture because you've done the surgery. The pathologist does not see that. So if you put it with the pictures, maybe at the end I'll try to put my slide back again. I don't think that's going to be possible now. Anyway, so conjunctival map biopsies is what we do for sebaceous gland carcinomas, where you know that this is a tumor that can spread in a pagetoid fashion. So you mark each of these lesions. So there are 4 which are around the limbus. There are 3 in the upper fornix, 3 in the lower fornix, 3 from the tarsus above and below. So if suppose you've removed 2/3 of one eyelid, so that would mean only one from the eyelid, of that particular eyelid, and of course you have 3 more from the opposite eyelid. Then you take one from the caruncle, because that is the final location through which it would escape into the tear drainage system. Okay, and put them, number them, and preserve a copy of that map in your OT records, so that once the reports come, you know which are the sites which are involved. Okay, it is not difficult. Your pathologist would be able to report it. Just start doing it, and I'm sure they'll start reporting. Okay. Roshman, do you have your presentation? Okay. Dr. Gupta.
Yeah. Okay. So when we are talking about pediatric proptosis, deliberately, I've put it as a different category of patients because there are a handful of conditions that will happen in a pediatric orbit, and most of them are very critical. So a PNT is a primitive neuroectodermal tumor, which is very virulent, and it has a certain similarity in histopathology to retinoblastoma. Retinoblastoma, of course, the orbital variation of retinoblastoma, as Dr. Seema Das pointed out. This, if untreated or if you just try to operate it, has survival rates less than 30%. However, and it has to be treated protocol-wise, combining chemotherapy, surgery, and radiation. And of course, we need to look for metastasis. A dermoid cyst is one of the commonest lesions you're going to find in the orbit anywhere. It is not strictly a tumor, it's a structural lesion, it's a hamartoma, and you will very often see this in children. You'll see it growing as the child grows, and it'll often be associated with a suture, most commonly the external suture, but it could also be an internal or medial suture. If it is in the orbit, you may not see a lesion outside and you're going to see a proptosis. This is another structural lesion which would mimic a proptosis in a child. This is a cyst associated with microphthalmus. And the way to go about it is actually, you don't need to do anything. You're not going to be able to salvage the vision. Later on, you can aspirate the cyst, put in a sclerosant, and later fit a prosthesis. Now, this is something we need to discuss in all children with proptosis. A child presents with proptosis, please do a peripheral blood smear. It may be that within an hour, even without doing a biopsy, you're going to get a diagnosis. This particular child, he's a 12-year-old, had been treated for anemia for a couple of months elsewhere. He's been given blood transfusion, etc., but nobody till now had actually looked at the fundus. So this typical white-centered retinal hemorrhages indicate you have a clear-cut leukemia. But even if you don't have this, and if the peripheral blood smear is normal, you might still find that the child has a granulocytic sarcoma, and the indication might just be anemia and slightly lowered blood counts. Langerhans cell histiocytosis is another condition in a child which is a transitional lesion, which is somewhere between a pure tumor and an inflammation. And it will appear as a very rapidly progressing proptosis in a child. It looks angry, but there's no pain. All right. And it might be mistaken for a rhabdomyosarcoma. But you'll see this very typical bone destruction. And all you need to do is actually an incisional biopsy. A curettage might improve the condition, or a steroid and chemotherapy might also be sufficient. However, in a Langerhans cell histiocytosis or eosinophilic granuloma, you need to check whether there are other lesions elsewhere in the body. So take a look at this child. There is a proptosis, not that much, but the vision is counting fingers. But you look at the lesion, it is a well-formed lesion which you cannot distinguish from the optic nerve. You can see the kinking at the end of the lesion. Okay, this is very typically an optic nerve glioma. And if you find such a thing bilaterally, you need to look for neurofibromatosis. Please do not allow anybody to biopsy this lesion. Very often, when you send this to an oncologist, if they are not aware of the nuances, they're going to say, oh, give us a biopsy. By doing a biopsy, you're actually going to cause more damage. So this child, after chemotherapy for vinblastine and carboplatin, at 25 months follow-up, she came in at 1.5 years of age. I have a follow-up up to 4.5 years now. But the child has viable vision, ambulatory vision in that eye. The lesion is not really going to shrink. Okay, even when you image, the lesion is going to be there. But you can improve the viability for the child. A rhabdomyosarcoma is one of the success stories of the last century. We are in the 21st century. It's one of the oncological success stories of the 20th century. When they started off at the beginning, the survival rate was less than 10%. Now it is more than 90%, and particularly in a child, and particularly the embryonal variety of rhabdomyosarcoma has a very good prognosis. Even when you see a child like this with such a big lesion, please don't allow the child to be exenterated, because once again, people who are not aware are going to insist on exenteration. Do a biopsy, and if you wish, do a debulking, safeguarding the structures, the recti and the optic nerve. And after a tissue diagnosis, after systemic workup, when the child is put on chemotherapy and radiation, this child, I have more than 7 years of follow-up. Because of the intensive chemotherapy, his growth has been stunted, but he retains a 6/9 vision in that eye. He did develop a radiation-induced cataract and underwent cataract surgery. Even after cataract surgery, he retains a 6/9 vision with normal ocular movements. So once again, what I'm trying to say is we don't really need to be scalpel happy and cut up all eyes with proptosis. Many of them will have indicators that you can do without a surgery. Another set of lesions that almost scream out their own names are the metastases. When you see a child like this, sometimes you'll have the parents once again saying that, oh, the child had trauma. Or another grimmer thing that you might think of is probably this child is a victim of abuse. However, if you take a look, you can see the temporal fullness. And if you look, it's not only one eye that has the ecchymosis. Please take a look at the other eye also. You can see the superior sulcus fullness. And overall, look at the pallor of the child. So something is going on there. Okay, so now when you image, you can see there are bilateral orbital lesions. And you saw the temporal fossa fullness? Take a look at this. There's a tumor within the orbit as well as in the temporal fossa. And you can see that the diploic space of the sphenoid bone here is enlarged. So we know that there is something going on systematically. And let us remember that this ecchymosis around the eye, even though it's present only in 40% of the patients, if you see it, it is pathognomonic for metastatic neuroblastoma. It's absolutely pathognomonic. You don't have to think further at all beyond this. You don't need to biopsy. In corroboration, we have the child has anemia. You saw the pallor, didn't you? Okay. So on USG abdomen, the child has a right suprarenal mass lesion. These lesions are actually, very bad prognosis, and the ecchymosis might finally disappear. Okay, so another metastasis is if you see a lady with a fullness in the right lower lid here, and there's a firm mass, you are talking about a biopsy. This has to be an incisional biopsy because the muscles are involved. You cannot excise the whole thing. And it turned out to be a neoplasm with single file tumor cells. So this is called an Indian file appearance, which is typical for lobular carcinoma of the breast. The treatment is with radiation, and you would also have to treat for radiation retinopathy. It may be presenting with limitation of movement. Did you count in the time that I was not presenting? Another typical feature, this is again pathognomonic of a metastasis. This is called a hang-up ptosis, particularly in serous carcinoma of breast. You will see when the patient looks down, the eyelid does not move down. Okay, proptosis alone is not going to cause that much of a lag of thalamus. It is desmoplasia inside the orbit. And you can see the lesion here. It might be a more obvious lesion where the patient didn't give us a history of a tumor. But you see the lesion here, you can see the bone erosion. And a rule of thumb is if a tumor is crossing the midline of the orbit, it is a malignancy. So we are looking at a possible malignancy, and just on inspection, I see the scar on the neck. And then the patient comes up and says, oh yeah, there was something in the neck which was taken out 4 or 5 years ago. And then we dig through the old papers, and this is a metastasis from papillary carcinoma thyroid. This is another hang-up ptosis. So among the bony tumors, this is an example of a mesenchymal chondrosarcoma. Even though it's so-called a chondrosarcoma, you're going to see a bony lesion. Most of the sarcomas will need complete excision. If they're not well circumscribed, this is a patient who's going in for an exenteration. In the lacrimal gland, an example of a mucoepidermoid carcinoma. Now, this is a special case. It's a fairly rare tumor, which can be mistaken for a cystic lesion. You'll see just how well circumscribed this is. Okay? And the other lacrimal gland tumor we should be looking at is an adenoid cystic carcinoma. Once again, you'll see it's crossing the midline, and if you compare the bony orbit on either side, you'll see erosion of the bone. So this is a patient where you would have to do an incisional biopsy. This could be going in for an excisional biopsy. And this would be an incisional biopsy. There can be associated pain and periocular altered sensation if there is perineural invasion. And this might be present in up to 25% of the patients, not in all patients. The treatment nowadays is not exenteration. We would want to do a chemotherapy and radiation. And why so? Because we know that the tumor-free survival after exenteration versus after chemotherapy and radiation is going to be the same. This is another example of an adenoid cystic carcinoma. You can see that it is kind of involving the rectus also. But if you excise it, saving the rectus, and this guy is a driver. I have a 3-year follow-up on him. We've saved the eye. He retains 6/9 vision and his entire ocular movement without diplopia. This is a scan of the mucoepidermoid carcinoma. You'll see these lucent areas. You might mistake it once again for a cystic lesion or a liposarcoma. The thing about mucoepidermoid carcinoma is that it can develop in a pleomorphic adenoma. So if you take an inadequate biopsy, you might think it's a pleomorphic adenoma. However, let's remember our rule of thumb. Because it is well circumscribed, take out the whole lesion. So among the neurogenic tumors, neurofibroma, as we talked about, has a very typical appearance. If you look at a scan, you'll see hypoplasia of the sphenoid wing. A schwannoma, once again, it'll have a slow growth, but it might have cystic degeneration. So it might look like a cyst. And you might have, after excision, you might have some loss of sensation or loss of movement, depending on what nerve it grew from. Optic nerve glioma we talked about. And this is once again a spotter. If there is a hyperostosis, this is a sphenoid ridge meningioma. optic nerve sheath meningioma, if you see an intracorneal tumor where you cannot distinguish the optic nerve, an MRI might distinguish it, and we will know that this typical tram track appearance is once again pathognomonic for an optic nerve sheath meningioma. The treatment is radiation. Once again, do not let anybody take a biopsy from there. I've had patients who were, misguided and had a biopsy and ended up with a worse field defect than they started with. This is not going to resolve with radiation. However, the fields will either stabilize or improve in 60% of the patients. So with that, I come to the end of this talk. Thank you very much for patient listening. Thank you, folks.
Dr. Roshmi, one question from my side.
Sure.
So, when do you decide between incisional biopsy versus a complete excision of the lacrimal gland tumor?
All right. So far as the lacrimal gland tumor is concerned, if it is a well circumscribed tumor, just take it out. Because even in a pleomorphic adenoma, if you have actually incised it, you are leaving it open to a recurrence. So, and pleomorphic adenoma, when it recurs, is very, very difficult to treat because it becomes diffuse and it seeds along the plane of incision. So, if it is well circumscribed, take it out. That is what I would say.
Thank you. Thank you, Dr. Anirban, for having me as part of your IC. And I'll be covering the surface tumors, which are very often mistaken as something benign and something less sinister, and very commonly seen in our practice, but very often missed also. So, looking at the anatomical slide of conjunctiva, this section shows that basically you have epithelium and you have stroma of the conjunctiva. Now, tumors can arise either from the epithelium or they can arise from the stroma. The epithelial tumors are far more common than the stromal tumors. We can understand these tumors better if we can just divide them into two parts by their color. So, one is non-pigmented and one would be pigmented. That way, if we classify it mentally, it will be easier for us to remember and also to understand how these things present. So let us start with the simpler ones. We'll start with the epithelial tumors, the non-pigmented ones. And this was a child who presented, a 10-year-old child who presented with a sudden bleed and a lesion on the conjunctiva. Parents were very concerned as to what it is, and they wanted an excisional surgery for this. But then they were counseled that this is simply a papilloma. At that age, what you see is usually a papilliform lesion is there. Is there a pointer? No. There's a pointer? Okay, anyways. So there is a, you can see that there is a papilliform lesion, and sometimes you may get confused that there is also a small feeder vessel going into that lesion. So is that malignant? No, a feeder vessel, single feeder vessel will not make it malignant. So look at the age of the child and look at the lesion. Usually these are benign papillomas. Even if you excise them and send biopsy, for biopsy, if the parents are very apprehensive, no harm done. But otherwise, if you can simply observe them or treat them with cryotherapy or sometimes interferon eye drops, these lesions can regress. Sometimes you have large conjunctival epithelial cysts which may assume a giant size, and one may get confused whether it's an orbital mass with cystic degeneration or something. In case of any doubt, you can do an imaging to see if there is an underlying mass behind and from which it is arising, or it's a simple fornical cyst. So if it's a simple fornical cyst, you will be able to excise it in toto just after giving an conjunctival incision. Now we move on to the more sinister ones and the more important ones, I would say, because it's very important not to miss these lesions. So, ocular surface squamous neoplasia is the term which we commonly use for epithelial malignant tumors, which are most commonly seen in our country in terms of conjunctival malignancies. So, this term encompasses histopathological diagnosis of dysplasia, carcinoma in situ, or squamous cell carcinoma, depending on the degree of dysplasia and the depth of invasion into the conjunctiva of the malignant cells. Now, there are various ways in which these lesions can present, and it will be good to have a mental image and an idea of how different ways that these lesions can take. But there are few common characteristics or common patterns that will arise out of these cases that you will see further on. And just remember those few points, and they will help you in making a diagnosis clinically in your OPD itself without taking the patient to OT for any biopsy or anything. So they can arise as present as a softish gelatinous mass on the limbus, and notice that there is a feeder vessel coming also. Other type of presentation which I would say is a little more common is a papilliform mass, and many times you may mistake it for a papilloma. But if it is the history is like a middle-aged patient or an adult patient presenting with the recent onset of a papilliform mass, why and with a lot of intrinsic blood vessels seen in the lesion, so suspect something sinister. The other thing is intralesional vessels. So focus on the lesion in your slit lamp, and if you see a lot of these vessels, which are like starting within the lesion and then looping and going within the substance of the lesion, suspect a malignancy. Feeder vessels I already mentioned. So most of these lesions will have very angry, prominent, multiple feeder vessels going to them from the fornices. So this is again a sign of malignancy. Another highlight is keratin. So you see this whitish layer on the surface of the lesion, and what this whitish layer represents keratin. Now, keratin is basically a result of increased cell turnover in these epithelial cells, and if you have this keratin over any of your conjunctival lesions, suspect malignancy first. Another patient with profuse keratin deposition, intrinsic vessels, lot of feeder vessels, and it's a large mass. So you know what you're dealing with is a malignancy without going in for an incisional biopsy or anything. You can straight away plan your treatment. Sometimes there may be a confusion with the nevus because in our population many times there will be pigmentation. So look at the other signs. So as I mentioned, there is a keratin deposition here on this tumor. So in spite of having a lot of pigmentation, which can be just a excessive melanocytic proliferation in some cases, but it's still a squamous cell carcinoma only. Keratin gives you the clue. Rarely you have a picture where this is just a corneal lesion without any limbal mass. Sometimes there may be a small limbal mass associated. Look carefully for that. But otherwise, it's an epithelial lesion which is advancing into the arising from the limbus and going towards the center of the cornea. So it may just present as a corneal lesion also. Also, I would suggest that I would recommend highly that when you see a patient of Wilson, always invert the lids to see the proper full extent of the lesion. That will help you to plan your treatment in a better way. Many a times we just look at the lesion in the interpalpebral area, miss out on the tarsal conjunctiva, and sometimes there is an extension of the lesion lurking there, and that may lead to incomplete treatment. So always invert, and sometimes you will see a diffuse lesion which is covering almost the entire bulbar surface, especially in elderly patients. This patient, you can see the lid is inverted and you can see there is a layer of conjunctival lesion which is overgrowing the normal looking conjunctiva. You can make out the difference between the two parts here. Rose Bengal staining is another modality that we have in our OPD. If you stain these lesions with Rose Bengal, they will take up the stain, and also sometimes you will see an extension of the staining around the lesion also. So that also means that the surrounding area is also dysplastic and you need to take out the entire lesion which is getting stained and not just restrict your surgery to the part which is obvious. ASOCT is a new modality which can help us sometimes in picking up invasion of the cornea or underlying sclera. In some cases, especially if there's been a prior surgery done and you want to plan a resurgery. UBM, this patient typically had some hypopion type picture presented with a hypopion in the anterior chamber, but the cells were slightly thicker and not like a typical infective hypopion that you see. On inquiry, she gave a history that there was something removed from the surface of the eye few months back. So you can see the scar here. This is a conjunctival scar, and you see this hypopyon type picture. And on UBM, you can see in such cases a ciliary body thickening. Basically, this was a squamous cell carcinoma of the conjunctiva which had gone inside through the ciliary body and caused an intraocular invasion. Unfortunately, in such cases, it's not possible to salvage the eye. You have to remove the eye, otherwise, this patient's life is at risk. And whenever you see patients like these xeroderma pigmentosa or immunocompromised patients, many a times these patients may have bilateral OSSNs also. So this one is grossly affected, but this also had a smaller lesion. So if you just focus on the bad eye, sometimes we may miss the other eye, which may have a slightly smaller lesion. So whenever you have a patient with predisposing risk factors like these, so you always be very careful in examining them properly, look at the other eye as well. So what we saw here is a pattern which was common between all these presentations, and so we came to few common points which can help us to diagnose these patients early on. That is intrinsic vessels in the lesion, feeder vessels, keratin on the surface, and staining positively with the rose Bengal stain. Now the treatment for these lesions is topical chemotherapy or surgery. Now please don't go back home and start all patients on chemotherapy. You have to understand where it is indicated and where it is not. So it's indicated mainly in intraepithelial tumors, not in the invasive squamous cell carcinomas. So sometimes you have a large tumor where a part of it is invasive squamous cell carcinoma and the other part is got a intraepithelial neoplasm. You give chemotherapy that helps to shrink the tumor and makes the surgery a little easier. Second is if you have done surgery but one of your edges has come positive with intraepithelial neoplasia, there you can start the patient on topical chemotherapy. Sometimes there are elderly patients who have already undergone multiple surgeries and there are multiple recurrences. On those patients, instead of subjecting them to more surgeries, you can try chemotherapy in these patients. Pure corneal OSSNs will respond well to chemotherapy. And sometimes you have diffuse lesions in which the only option is exenteration, uh, and they cannot be, the local excision is not possible in those patients also. I would suggest you can give it a try. Sometimes that intraepithelial neoplasia component is there, which may regress and leave you with a well-defined mass, which you can later surgically remove. The point here is that what more important thing is that you have to see where the patient is coming from. Is he able to follow up with you periodically? Is he able to afford the medications and frequent visits? Otherwise, if the patient is coming from far away and you socially is not able to travel easily, some child is bringing, and the patient is already neglected with a diffuse tumor, why to subject the patient to multiple visits and risk losing the patient to follow up? Better to subject the patient to surgery directly. That is the treatment of choice actually. So these are few examples where topical therapy has worked. This patient presented with a gelatinous mass on the limbus, and after a few cycles of a few months of interferon therapy, the mass has regressed. You can see. Another patient with a large mass with prominent feeder vessels responded very well to interferon treatment. We can also use mitomycin C or 5-FU. They are cheaper options, and mitomycin is more effective as well compared to interferon, but some surface toxicity is there. But if patient can afford, so interferon is the safest one, but mitomycin is the most effective one. So surgery is the standard of care for invasive squamous cell carcinomas. I have not put the video in interest of time. So what you do is you go around the tumor without touching the tumor and take about 4 millimeter of clear conjunctiva all around, and then you cryo all the edges of your margin of the edges of the surgery, and then you cover it with AMG. So this is how it looks like after surgery. So you can clear up these tumors very well with surgery. And if you have any doubt of invasive squamous cell carcinoma, don't waste your time with topicals. Straight away go for surgery. Another patient after surgery is doing well. Now we move on quickly to the pigmented tumors of the conjunctiva. So the common ones that you will see are nevi, racial melanosis, PAMs, or melanomas. These are some of the common pigmented tumors. So this is the most common one. Mostly children will be brought by their parents concerned about a pigmented lesion on the conjunctiva which is growing in size. So I'll tell you, if you look at these, if you look carefully at this lesion and you see these kind of hollow spaces or cysts within the lesion of substance of the lesion, then suspect it's a nevus only, and just counsel and reassure the parents that nothing needs to be done and just observe. Occasionally, you may have one or two feeder vessels also going in there, but that is nothing to worry. Typical locations for nevus is in the interpalpebral fissure. You may have it on the plica, you may have it on the caruncle. But if a nevus presents in adulthood or undergoes a sudden increase in size in adulthood, or there is a recent color change in an adult who had a nevus all along, and if the location is other than bulbar conjunctiva, plica, or caruncle, or if there are prominent feeder vessels, or it recurs after excision. So these are the points which should make you suspicious and cautious, because this may highlight an underlying malignant transformation in the nevus. So be careful when any of these signs are present. So treatment for a confirmed nevus is observation. Just you don't need to do anything. If the family is very apprehensive or you have any doubts, go ahead, excise and cryo the edges. Complexion related melanosis basically is what we have in our country and also in a lot of African countries where the sun exposure is very high. So you have diffuse pigmentation in the interpalpebral fissure, and it is usually present bilaterally, although it may be asymmetric still. You don't need to do anything about it. Sometimes you may see these grayish patches on the conjunctiva, but if you look carefully, they are not on the conjunctiva, but actually deeper to the conjunctiva in the episcleral layers. This is called as melanocytosis, and the associations sometimes are more serious than just the pigmentary lesion that you see. Sometimes they may be associated with uveal melanoma, glaucoma, or also if you ask them to open the mouth, then you may see palatal pigmentation, which may also highlight esophageal melanoma. So you have to send these patients across for appropriate referrals as well. Now, this is PAM. It's important to recognize this entity as it is responsible for a lot of cases which develop melanoma eventually. So that is why it is important to understand about it. So it presents as the name suggests, it's an acquired melanosis. So a middle-aged person will present with a recent onset pigmentation of the surface of the eye. And when you look at it, it's not well defined. It's got fuzzy borders, ill-defined, and it may also show some patterns of waxing and waning type. So sometimes the patient will say it is increased or maybe it has gone down, and there may be multifocality. You may have some lesion on the another space like bulbar conjunctiva as well. So we have a complete look at the lesion. So what we need to understand is that if you biopsy these lesions, there will be two types basically: without atypia, with atypia. Without atypia, there is no risk of malignancy. With atypia, there can be almost 46% risk of malignancy in these patients. Management depends upon the extent, which may vary from surgery to topical therapy. Uh, Sometimes these PAM lesions may develop into frank conjunctival melanoma, which will be highlighted by a dark pigmentation and nodularity of the surface on the conjunctiva. You may have it on the tarsal conjunctiva as well, or the palpebral conjunctiva, which may spill over onto the skin side, as seen in this case. This is typically arising from pre-existing PAM lesion. You can see this pigmentation, which is PAM, and it has converted to melanoma. Another patient, fornical pigmentation, PAM, and converted to uh, deep dark pigmentation associated with nodularity, suspect a melanoma. Now, most of these conjunctival melanomas, up to 75%, are associated with PAM, and about 20% are associated with nevi. So, be very careful when you are dealing with PAM and don't ignore it. Melanoma is a very serious kind of a malignancy with a systemic metastasis rate of about 9 to 25% and lymph node metastasis almost up to 40% sometimes. Management options for melanoma are excision with cryo as for OSSN, plaque, brachy if it's also invading the stroma, and or the episcleral layers, and orbital exentration if it is very extensive like the two cases shown. We also need to look at the lymph nodes and subject the patient to lymph node dissection if lymph nodes are positive. This sentinel lymph node biopsy technique basically used to recommend you to pick up lymph node metastasis at an early stage, and any tumor more than 2 millimeter in thickness, it is suggested that you do sentinel node biopsy, but it is not available easily. So simple neck imaging, CT or MRI neck imaging with a thicker melanoma and referring to an appropriate neck surgeon may do the job. Lastly, there are some lymphoproliferative tumors which may appear as pinkish subconjunctival masses. These are basically some mostly extensions of the orbital lymphoproliferative pathologies like lymphomas, and you need to treat them after systemic evaluation if there is a systemic component or not. In unilateral cases, 17% is the chances of progression to systemic lymphoma if patient is presenting with the orbital one first. And in bilateral cases, the percentage of having a systemic lymphoma goes up to almost 50%. So to conclude, a good clinical understanding of the features and signs of these tumors is helpful to pick up these lesions early and manage them timely. Thank you very much.
Can you just put up a picture of an OSSN? Any of the pictures of OSSN. What the question is, how many of you are treating OSSN in your individual capacity? Show of hands. Okay, and how many of you are using topical chemotherapy as your primary mode of treatment? Dr. Ganguly. Okay. My question is, how do you decide when are you going to use, when are you going to do topical chemotherapy? When would you decide, no, I will do surgery instead? How do you make that decision? What has happened is that interferon has become more easily available. Because it works in a lot of patients, we sometimes use it indiscriminately. Can you just show that picture again?
It's not showing up on the screen. They've disconnected.
We are winding up. We are just in our discussion phase. We have to leave the hall at 1:25, right? So can you show us that last slide? Okay. So how would you take a decision of whether to give topical chemotherapy as your primary or do a surgery? No, that is one thing he said, that if your patient is not able to follow up, then surgery would be a better option. The other is there a clinic, is there a...
Also the chemotherapy should
Puneet,
have...
you want to say something?
Gaurav.
Gaurav? No, see, a flat lesion like this, okay, this looks pretty keratinized, right? But is there an investigation that you can do to decide whether it's invasive or non-invasive so that you can... ASOCT. So if you have an ASOCT and it does not show invasion, you are safe to continue with topical chemotherapy. Now, in a situation like this where there is a lot of keratin, the laser may not penetrate the lesion. It might not tell you what is the depth of invasion. In such a situation, it is always safer to do a surgery instead. Okay, that is the point that we wanted to make. Thank you very much for having attended this session. I hope it was useful to you and you can take it back and use it in your practice. Thank you very much.